Good evening and welcome everyone to our 2024 Adult Epilepsy Conference. My name is Jeanette Locke and I am the Multicultural Outreach Coordinator for the Epilepsy Foundation of Eastern Pennsylvania. And we are excited to be here with you this evening, and we have a wonderful program for you. We will be hearing from two of our experts, Dr. Scott Mintzer and Dr. John Khoury. And the topics for this evening are driving and sleeping. Okay, so first and foremost, thank you for attending. Please take a few minutes to start our survey. It should be on your screen at this point. So before we get started, just want to make sure that we do the survey. We want to make sure that you understand that your audio and your video will be muted for the entirety of the program. However, if you have any questions, please feel free to add them to our chat, and we will pull them up at the end of the program after each presenter, and we will present the questions. Okay, so here at the Epilepsy Foundation, we want you to know that you're not alone. 3.4 million people in the United States live with epilepsy. 1/3 of the people with epilepsy live with uncontrollable seizures because no available treatment works for them. And 1 in 26 people in the United States will develop epilepsy at some point in their lifetime. 6 out of 10 of those people have no known causes for their epilepsy. And 110,000 people in Eastern Pennsylvania do live with epilepsy. So here we have our map of the territories that we serve. We serve 18 counties in Eastern Pennsylvania, and we are focused on education, support, and advocacy. And we're here for you, and we have been for the past 50 years. Some of our programs and services that we have here at the Epilepsy Foundation, one of them being seizure recognition and first aid training. We have monthly support groups, and we have one for each and every one of the counties that we serve. So if you're unable to meet at one of the locations, you can jump on any of our support groups. We would love to have you. A lot of the times, or most of them are virtual. So if you can't make your specific support group, you can always jump on any of the other ones. We will be glad to have you. A lot of the programs that we have are our advocacy efforts, community and awareness events. We have youth, young adult and adult services, retreats and camps, educational conferences, and webinars. And we also can help you with information that you may need and referrals. Okay, and then we have 3 mental health programs that the Epilepsy Foundation of Eastern Pennsylvania offers. The first being Hopscotch, which is our home-based self-management and cognitive training changes lives. A one-on-one coaching program designed to help people with epilepsy find ways to manage and cope with memory problems. We have PACES, which is the program of active consumer engagement in self-management. And this is a virtual group program designed to increase the medical, psychosocial, and community adjustment of adults living with epilepsy. And finally, the third mental health program that we offer is Chronic Disease Self-Management Program, which is also a virtual program. It's a group program designed to help individuals with epilepsy and other chronic health conditions. And they learn how to manage techniques to manage the problems common to people living with chronic health issues. And it doesn't have to be just epilepsy. Some people have epilepsy and other chronic diseases that is helpful for that. Okay, how you can be involved. You can involve yourself with the Epilepsy Foundation to raise awareness and to share your story. You can volunteer and be an advocate. Invite the Epilepsy Foundation to lead a seizure recognition and first aid training session for any event that you may have or your workplace, schools. We are more than willing to come out and do our seizure recognition and first aid training. You can attend and fundraise for the Epilepsy Foundation events. Please visit our website at efepa.org and follow us on social media. Okay, so here are our upcoming events. If you are interested in any of these events, maybe you can take a screenshot or a shot with your phone so that you can have the upcoming dates so that you can add them to your calendar. Okay, so our schedule for this evening is as follows. So I just did my part and that was from 6 to about 6:15. Our first session will be on driving with Dr. Scott Mintzer. He will discuss driving laws for patients with epilepsy in different states and how decisions are made regarding driving for patients with seizures. Then we will have a 15-minute break, and then we will have a presentation on epilepsy and sleep by Dr. John Khoury. Good sleep is vital for controlling epilepsy, and Dr. Khoury will discuss techniques, improving sleep, and the latest advancements in self-care. Okay, so let's get ready for our first presenter. If you're ready, it is my distinct pleasure to introduce Dr. Mintzer. Dr. Mintzer is a professor of neurology and director of the Epilepsy Monitoring Unit at Jefferson Epilepsy Center in Philadelphia. Welcome, Dr. Mintzer. Thank you so much for joining us and sharing your expertise with us. I will now stop share and you will have the floor.
Thanks, Jeanette. Appreciate the introduction. Let me make sure I get my presentation up here. Okay. Everybody can hear me and everybody can see my slides, I hope?
Yep.
Yep. Okay.
Yep, sounds good.
I'm here to talk to you today about driving and epilepsy, which for patients with seizures is either everybody's favorite topic or everybody's least favorite topic, I guess, depending on your perspective. It is certainly something that people constantly ask about and are concerned about, and that's why I thought it would be a good topic to discuss with you today. When doctors present to other doctors, they often start with a patient's case history. So I thought that I would start likewise. And so I'm gonna, I have, this is a made up case, but we see patients who have various issues like this all the time. And so I thought I'd, give you what it looks like from our perspective. And so you can think about the issues and you can see how we think about the issues. So this patient is a 26-year-old woman who developed focal seizures about 4 years ago. With the seizures, she blanks out and she smacks her lips for 45 seconds. So it's pretty typical of the kind of thing that we often see for this kind of seizure. She was started on lacosamide and the seizure stopped. So then later on, she developed a second kind of episode, something different. Sorry, hang on one second. I just have to delete something from my screen. Okay. Sorry about that. She then developed a second kind of episode where she had loss of awareness and flopping over with her eyes closed for 5 minutes, and her doctor brought her into the epilepsy unit and confirmed that those episodes were what we call psychogenic seizures. They're stress seizures. They're functional seizures. They go by various names. Many of you may have heard of these. They're basically things that look like seizures, but they're psychological in nature. And so now this patient actually has both. She has epileptic seizures and she has the psychological seizures. And that's something that we see fairly often. Meanwhile, at the time she goes to see her doctor, she's had none of her epileptic seizures for 3 years. So her epilepsy is doing great. She still has her psychogenic seizures every 2 or 3 months. And she also tells the doctor that, oh, by the way, my partner and I actually are looking to have a baby soon. So here are the questions to think about. Think about this. What would be going through the doctor's mind if you were the patient or if this was your loved one? Think about these issues. Number one, should she be permitted to drive at present? Number two, does the doctor have to report her psychogenic seizures to the state? Number three, she wants to get pregnant. So if the doctor says, okay, you want to get pregnant, let's take you off your medicine, should she still be allowed to drive? Okay, let's say the doctor says, well, I'm not going to take you off your medicine, but instead I'm going to switch you to a different medicine that's safe in pregnancy. Let's switch you to lamotrigine. Okay, so she switches to a different medicine. Should she still be permitted to drive? So all of these are questions that might come up in this patient's case, and are emblematic of issues that we are faced with and that you are faced with as patients when the issues about driving and epilepsy come up. And so we'll start off with the perhaps obvious statement that driving in epilepsy is complicated. It is more complicated than most healthcare issues because, of course, not only are you talking about risk to yourself, but you're also talking about risk to others. That really makes it dramatically different from most other health concerns that we come across. I mean, we don't want patients to risk themselves in any capacity for anything. And it's our job as doctors what to tell you as patients when you're putting yourself at risk. It's also true that as a patient, you have a right to put yourself at risk. I mean, people do silly things for their health all the time. And I don't mean that in a smart aleck way, like doctors are patients too. And sometimes doctors do stupid things for their own health. So you have the right to do something stupid for your own health, but you don't have the right to jeopardize other people. And that's where, driving in epilepsy gets really complicated because if you drive and you have seizures, you're actually risking other people on the road. At the same time, it's not so simple as saying, oh no, you can't ever have any risk to anybody because you do have to have some freedom to live your life too. So when you put all that together and it gets complicated and it gets difficult to make judgments. The states have laws about these things. Um, but there are a lot of things that aren't covered by state laws, which we're going to talk about. And so then sometimes you just have to go with sort of what experts' consensus is, and sometimes there isn't even a consensus. So this is just an introduction to how complicated this all is. So we're going to start off talking by state laws. And when we talk about state laws, there are two separate kinds of state laws that you have to keep in mind. There are the driving laws themselves. In other words, how long do you have to be seizure-free before you can drive? Are there any exceptions to those? And then there are the reporting laws, the laws that dictate when physicians have to report things to the state. That's separate from whether you can drive or not is whether those seizures have to be reported. So let's talk about all that stuff now. State laws in terms of how long you have to be seizure free in order to drive vary a lot according, by state in America. Various states, in some states it's 3 months, in some states it's 6. In a few, it's 12 months. The worst one, if you look at all of the states in America, the harshest one is Rhode Island, where you actually have to be seizure-free for a year and a half before they'll let you behind the wheel, which I think is particularly ironic because Rhode Island is like this big, and I mean, you drive through the whole thing in half an hour. But that's a really exceptional rule. Around here, as you can see at the top bullet points listed, we have more typical seizure-free intervals. Both Pennsylvania and New Jersey require you to be seizure-free for 6 months in order to be able to drive. And 6 months is probably the most common time interval in America. And if you ask most seizure specialists, they will tell you that if you ask them, what do you think it should be? Most seizure specialists would probably say that it should be 6 months. So most of us would agree that those states probably have it right. Delaware is more lenient. In Delaware, you only have to be seizure-free for 3 months before you can get behind the wheel again. There are also a number of states, especially in the West and Midwest, that don't actually have a firm number. They say that it's actually up to the physician. I actually dislike that. I think that's a problem because I think it puts the physician kind of in an impossible position. So I actually think it's better when the state makes that decision. And for the states around here, the state has basically made that decision for us. Now, in the state of Pennsylvania, there are specific driving exceptions. Pennsylvania says if you have a seizure, you can't drive for 6 months unless you meet one of these 4 exceptions. And they have the 4 exceptions very clearly laid out. The 4 exceptions are these. First of all, if you have a specific prolonged aura before your seizures, please note prolonged. If you have an aura for 10 seconds before your seizure, that is not prolonged. That's not long enough to prevent an accident, which is why it's not something that is used to allow people to drive. A prolonged aura would mean an aura that lasts at least for several minutes, at least, 5 minutes. It's not actually defined, but I would want it to last at least several minutes, long enough to be clear that you would have plenty of time to pull over a car. And that has to be reliably there basically all the time. A second exception in Pennsylvania is if you have an established pattern where you only have seizures in your sleep or you only have seizures right when you wake up in the morning. There are certain kinds of epilepsy where people have seizures usually within a half an hour or an hour of waking up. So for those people, if you have a really established, reliable pattern, then you just know you wake up in the morning and you don't get in the car for the first hour to make sure you don't have a seizure, and then it's safe for you to drive. But again, it has to be an established pattern that's only you only have seizures in your sleep or within the first hour of awakening. And the state defines that as that you've had that pattern for at least 2 years. A third exception in Pennsylvania is if the seizure was due to a prescribed change in medication. This is very useful and very important. So that means, let's say you and your doctor decide, hey, I want to try to come off my medications. Okay, we'll give it a shot. Let's lower your medicines. Let's take you off. And then you have a seizure. So as long as your doctor puts you back on the old medicine, that your doctor can then say to the state of Pennsylvania, this was due to a prescribed change in medication. The patient's back on the drug that kept them seizure-free for a while, and the state will actually let you keep your license. Please note that it is a prescribed change in medication. If you change your medicines on your own, you are not covered by this. So that means you should always make sure if you think you want to try to come off your medications or change your medications, please make sure you talk to your doctor so that, because if your doctor orders it, then it's prescribed and then you're covered under this exception. If you do it on your own, then you're not. Finally, the last exception is if you have a seizure that's just due to an illness or a toxin or basically something medical happens to you. If you got some horrible, serious infection and you were hospitalized and you had a seizure, then we could say, well, you only had the seizure because you had that horrible infection. And if your doctor attests to that, then Pennsylvania will still let you keep your license. So these are the exceptions. These are the only 4 exceptions. If you don't meet one of these 4 exceptions, Pennsylvania doesn't want to hear about it. Honestly, that's the truth of the matter. They will not make an excuse, and it doesn't matter what your doctor says, actually. Your doctor can write a letter to say, but this and but that, but it actually doesn't make a difference. The state will not listen to them. So these are the clear exceptions in Pennsylvania. Now, separate from the laws about how long you have to be seizure-free, as I mentioned, are specific laws about reporting. It turns out that of the 50 states, there are only 6 states in America where doctors actually have to report people to the state for having seizures. 3 of those states are out west, California, Nevada, and Oregon. And lucky us, the other 3 are right here, New Jersey, Delaware, and Pennsylvania. What a coincidence. I actually did my epilepsy training in California. I worked in Illinois for a few years, but basically, by coincidence, I've basically lived my entire career in places that where seizure reporting is mandatory. So I've been accustomed to doing this for many, many years. Each state has slightly different reporting laws. We don't have to go into this in great detail, but I'll just point out at the top there, you see the Delaware reporting law. I'll point out Delaware says failure to do so is punishable by a fine. So in Delaware, you don't complain if your doctor says, I have to report you to the state. I mean, don't complain to the doctor because the doctor's literally going to get a fine if they don't do it. In New Jersey, they say that you have to report seizures that persist or recur despite medical treatment. So in New Jersey, you don't have to report a first seizure. If someone has a first ever seizure, then they get put on medication. That's fine. But if they have a seizure while on medication, then that has to be reported to the state of New Jersey. And finally, Pennsylvania physicians and other providers have to report all disorders characterized by lapses of consciousness. It also says physicians are not civil or criminally liable, so that means you can't sue your doctor for this. This is a thing that the state requires us to do, and we frankly don't have a choice in the matter. One other thing to mention are commercial driver's licenses. This ends up coming up with people who are truck drivers or drive school buses and things like that. All of those, basically all states, those revert to federal law. And federal law is to have a commercial driver's license. You have to be seizure-free for 8 years. Yes, that is a very long amount of time. But the rationale there, of course, is that if you drive commercially, you spend much more time in a vehicle than someone who just drives, every once in a while to get places. So you're at much higher risk for doing damage to other people just from how much you're spend behind the wheel. And also, of course, if you have a commercial driver's license, that means you drive a vehicle that is extremely large and is liable to cause a lot of damage. Because of that, the law is very strict and very broad. And 8 years is actually a reduction. I think it used to be longer than that. So unfortunately, it is often the case that if you have a commercial driver's license and that's what you do for a living, and you have a seizure, I'm sorry to say this if this is relevant to anybody out there, but it is often the case that you're just going to have to change careers because it becomes too much of a risk to other people on the road. Now, um, not every seizure prevents you from driving. There are specific aspects of seizures that make it so that it's not safe for you to drive. The most common one by far is that there's loss of awareness. In other words, you blank out, even if it's for a second or two. Obviously, you might only blank out for a second or two, but that's obviously brief enough to crash your car. So if there is any loss of awareness with your seizures, no matter how brief, then it is not safe for you to be driving a car. Other things that may make it difficult to drive a car or impossible to drive a car is if you have a seizure that interferes with the movement of your right leg so that you can't get on the pedals, or movement of your dominant arm so that you can't control the steering wheel. If there's anything else, if there's any kind of funny feeling or any kind of twitching movement that would impede your ability to control the car, then obviously it's not safe for you to be driving. And finally, all of these things may be it may be okay for you to drive if you have a reliable aura, only if it's long. And I mentioned this before. There are studies showing that just having an aura is not good enough. Patients who have an aura, a regular aura, which usually lasts for several seconds, 10 seconds, 15, 20 seconds. Unfortunately, those folks have rates of car accidents that are no different from from patients who don't have an aura. So a brief aura, which is what most people have, is not enough to guarantee your safety when driving. Only a reliable aura that is long, again, minutes long, long enough for you to be able to pull off a car if you had one. It's important for those of you who do have seizures to recognize what you can't know. So what do I mean by this? Obviously, you're all aware of the fact, and we've been discussing the fact that seizures can impair your awareness. You become unaware with many seizures, with a whole lot of seizures. You become unaware of what's going on around you. The part that is particularly tricky is that you as the patient may or may not be aware of your unawareness. What I mean by that is this. Sometimes for many patients who have seizures, when you have a seizure, it's almost like falling asleep in front of the TV. Let's say you were watching Netflix and you fell asleep in front of the TV. What would happen? You'd wake up and you'd feel a little confused and you'd look on the screen and you'd say like, oh, Netflix turned off or it went on to the next episode and, I spilled my popcorn on the floor. I guess I must have had a seizure. So that's how I must have fallen asleep in front of the TV, I mean. So that's how you know that you fell asleep, right? So for many people with seizures, it's similar to that. You come to and you say, "Oh, there's a gap in time here. What happened? I'm missing something, and my blankets are all over the place. So clearly, I know I must have had a seizure." That's how it is for a lot of people. But for some people, it's not like that. For some people, not the process of recovering from a seizure makes it so that you don't even realize that you lost a piece of time. And this can actually be very, very important because it means that when we are making judgments about whether it's safe for you to drive as physicians, we absolutely must get a history from someone else who has seen them. You may not recognize that you have blanked out for some period of time, and it's not your fault, and it's not a character flaw, and it's not a judgment on you as a person. It's just the nature of the disease that you may not always be aware of that, and that's why we always have to get a witness history. I'm now going to tell you a really sad story. I debated whether to tell you guys this story, but in the end, I think you should understand both some of the issues involved and some of what happened. So I decided I want to tell you this story, and this is actually a true story. There's a woman with epilepsy within her 50s, and she was having seizures where she would blank out and stare for a minute or two, and afterwards she would be confused for several minutes. The very typical seizures, probably similar to what a lot of you had. And the thing is, she was not aware when these seizures happened. She was the kind of patient who she would come out of these things, but not be aware that she had lost a piece of time because of the process going on in her brain. She also lived alone, and she didn't see her family that much, just every once in a while. So she was having regular seizures, but she didn't know about them. And there were a few people who saw them. Her son saw her have a couple once when she came for a visit, and some people at work saw them once or twice, but nobody actually thought to tell her that she was having them. And she did not know that she was having them. So she thought everything was fine, and she continued to drive, not because she was irresponsible, not because she didn't care, but because she just didn't know that they were happening. So at some one day while driving, she just stopped in the middle of the road, right in the middle of the road, and traffic backed up behind her, and people got out of their cars to see what was going on, and they went to check on her, and they found her staring and looking confused, and so they called the police, and the cop came over, and he was trying to get her attention, and nobody could actually get in touch with her because she was just so out of it, and they couldn't get her door open because her door was locked, and so in the confusion, she clearly had a seizure when this happened. And so in the confusion period, she actually just drove off. And the cops pursued her. And before they could get her to stop, right down the road was a high school that was just letting out for the day. This was about 3 o'clock in the afternoon. And in her post-seizure confusion period, and it seems she probably actually had a second seizure while this was happening because she actually struck a car with two teenagers in it, and she tragically killed them both. And she was discovered sitting in the car just looking completely confused and out of it and not being responsive to anything around her. So she clearly went and had a second seizure when that happened. And the reason I'm telling you this story is for two reasons. Number one, because obviously, unfortunately, I want all of you to understand, that issues about driving and seizures can occasionally have really serious and dire consequences. And the other thing I want you to understand is what I was talking to you about before, that you, as a patient, you may not always be aware of whether you are aware or not. And that's why it's absolutely crucial for your doctor to get a history from someone else who has seen your seizures and can tell whether you are fully with it or not. And we don't want, obviously, nobody wants horrible things like this to happen to anyone. Now, on the other hand, here's a better story for you. Sometimes the patient's absolutely right. And this is also a real story. I had a patient of mine who was in his 40s, and he had seizures where he'd get a funny feeling in his stomach and then smack his lips over and over again. Again, typical seizure. But he claimed that when he had this, he was completely awake and alert, and he claimed he didn't blank out at all. He often drove his 10-year-old daughter around, and his daughter would sit in the back seat and said that she'd seen him have these while he was driving, and he never had a crash. He never did anything. He never even had a close call. And he said, well, yeah, that's because I'm awake when they happen. I'm fine. But his wife, of course, was petrified. His wife was like, oh my gosh, you're going to kill yourself and you're going to kill our daughter? You can't be driving. And she told me, like, Doc, you got to stop him from driving. And I said, all right, well, let's actually see what's going on. So I actually admitted him to the video EEG unit. And when I admitted him to the video EEG unit, we took him off his medicines and we captured his seizures. And when he had his seizure, we were actually able to test him to see what he was like. And guess what? Guy was completely 100% awake. He had his funny feeling. He would repetitively smack his lips, but he was completely aware and could completely respond and completely do everything we asked him while that was going on. So he actually was 100% correct. He actually did preserve awareness during his seizures. And that was good. I was actually able to prove that to his wife, that he actually was not endangering himself and his daughter, and I was able to allow him to drive. So while there are sad stories, sometimes the patient is right. Now, some of these issues are clear cut and they're covered by law, but there are a whole lot of things that are not covered by state law. So there's no state in America that has a law about what you do with driving when patients switch seizure medications. No state has a law about what to do with driving when you reduce medications. No state has a law about what you do with driving when come off medications. And Psychogenic or stress or functional seizures, that other thing that I talked about at the beginning, is also a very, very murky area where it's not clear how state law applies. So these are things where the law doesn't tell you what to do, and it would be nice if there was some consensus amongst the experts, but the truth is that epilepsy specialists don't always agree about what to do with these things. So I'm just letting you know that when it comes to these issues, they are very tricky. The judgments are difficult, and just being honest, you might actually get different opinions from different doctors about what to do about this. Um, I have a slide here just to show you some data from some actual medical studies. So the slides are a little busy, but let me just show you quickly some numbers. That table at the top is shows you the risk of seizures after the risk of a second seizure after a first one. So you look over on the left and it says time after index seizure. So the patient's had a seizure. That's how many months they've then gone without. And some of these patients actually got treated after their first seizure, but most of them didn't, or a lot of them didn't. We often don't treat people after a first seizure. So if you look on the right-hand side, it says delayed treatment. And so those are the patients who did not get treatment. And so that you can see, for example, if you have a seizure and then go 6 months seizure-free, your chance of having a seizure in the next 12 months is 18%. If you go a year seizure-free, then your chance of having a seizure in the next month is 10%. And it sort of doesn't change much after a year. So you may say, well, okay, is that a high number or a low number? In the UK, they have a threshold that they use, and their threshold is 20%. If the risk is 20% or less, then they feel that it's reasonable to resume driving. So based on this data in the UK, if you had a single seizure, first ever seizure, then if you went seizure free for 6 months, your risk would be 18% and it would be okay to drive. So that actually validates the state laws that I gave you before, that I told you a lot of states, in fact, most states, it's 6 months, including Pennsylvania and New Jersey. In the second table, the one at the lower right, shows you similar data in patients who had breakthrough seizures. So that means patients who have epilepsy, they were on medication, they had a breakthrough seizure, and then you look on the left column, it says how long were they after their breakthrough seizure? And on the right, you can see the risk of seizure over the next year following that. So if you have epilepsy, you have a breakthrough seizure, you wait 6 months, your chance of having another seizure in the next year is actually 32%. That's actually kind of high. If you wait 9 months, it goes down to 24%, and you have to wait a year to get it to go down to 17%. And so based on this data, actually, the authors said that, if you have epilepsy and you have a breakthrough seizure, you should probably not drive for a year. There's no state laws don't change for breakthrough seizures. So for state laws, if it's, in Pennsylvania, 6 months is 6 months. But you should all be aware that the 6 month time frame for Pennsylvania and New Jersey, for example, is actually pretty liberal for patients with epilepsy who have breakthrough seizures. And waiting even less than that would clearly not be advisable. And if anything, we might want to consider waiting longer than that. But the state law is what it is. And so these are some justification for why, even though it can be very, very difficult to not drive, why you still have to wait 6 months. Now, here's some more data to show you about driving after reduction in medication. So the top table there shows you take someone off medication. You wait 0, 3 months, 6 months, 12 months. What's the chance that they're going to have a seizure in the next year? So if you take medication away and immediately look at things, the chance of them having a seizure in the next 12 months is 30%. If you wait 3 months, then the chance of having a seizure goes down to 15%. And then if you wait 6 months, it goes down to 9%. So I think this is good rationale for what's always been my practice, which is that if you take someone off medication, they need to not drive for 3 months. That's what I do in my practice. However, I will say that this is an issue about which many different epilepsy doctors have different opinions. But this is part of a justification for my rationale that if you want to come off medication, you need to hang up the car keys for 3 months. We'll skip that second table because I want to go on to discuss some other things. I mentioned before the issue of psychogenic seizures. Psychogenic seizures, I think many of you may be familiar with them. They're episodes that look like seizures, but there's no abnormal electrical activity in the brain. And they're basically a psychological stress reaction, often due to something traumatic that's happened in your life. Some patients have psychological seizures only. There are many patients who have both epileptic and psychological seizures. There's no specific law about psychogenic seizures, and the application of the law to these things is actually very murky. And there are different opinions amongst seizure specialists about this. I personally believe that patients with stress seizures should be allowed to drive. I think that patients who have stress seizures, those seizures don't represent a true, brain derived loss of consciousness in the same way that an epileptic seizure does. There's data showing that patients with psychological seizures have a very low risk of having a car accident. And I think it encourages independence to allow people with psychological seizures to drive. But again, different epilepsy experts have different opinions on this. So I'm giving you my opinion just to let you know what I think. But your doctor may actually think differently about that, and you should ask them about why they have the belief that they do, if this is something that is relevant to you. Um, Driving with in the issue of epilepsy, of course, is a big issue, not just because you want to get to the grocery store or because you want to socialize with friends, or maybe you have, relatives you want to take places, but most of all, it's important in America because it's the way most people get to work. And unfortunately, um, this can actually get into an agonizing difficulty in a lot of patients with epilepsy. There are some patients who have seizures, but just only very occasionally. Let's say you have a seizure once a year, or there are patients who go even longer than that in between their seizures. And if you have infrequent seizures, it doesn't change the state law that when you have a seizure, you can't drive for 6 months. And it's going to be, let's say in Pennsylvania and in New Jersey, it's going to be 6 months every time it happens. Um, of course, if you only have a seizure once a year or once every 3 years, that depending on what you do, but probably that's not going to prevent you from doing your job. The large majority of people who have a seizure once every 2 years can perfectly well do their job, whatever their job is. So unfortunately, you get this agonizing circumstance where, that you're perfectly capable of doing your job, but you still have a major problem because you can't get to your job. Um, and it's not like your doctor is going to get you, is not going to be able to put you on disability for having seizures that are infrequent. We are not the ones who decide disability, by the way. Disability is generally decided by insurance companies or by the federal government if it's Social Security disability. And they generally have pretty clear criteria. You get disability for seizures if you have 2 seizures a month or 3 seizures a month, or, they have a certain number, but that's their number. And if you have a seizure once a year, they will say, well, you're not disabled. You are perfectly well capable of working. And they are right generally. But the problem is it doesn't help if you can't get there. Um, I bring this up just because I know that it's such an important issue for so many people with seizures. I wish I had an answer to this conundrum, and I really don't. But it is a problem that people often find themselves in. And it's very, very difficult for patients. And we as doctors know that this is a terrible position to be in, even though our ability to do something about it, honestly, may be limited. So what can you do? Well, I mean, first and foremost, the most important thing is to just make sure you are as good as you can be about taking your meds. Every dose, every day, if at all possible. With respect to the issue of driving, you need to realize that missing doses doesn't get you a pass. If you have a seizure because you missed some doses of medication, you still had a seizure. There's no state exception for that. And you're still not going to be able to drive for 6 months. So, I mean, I have lots of patients who are very good about taking their medications and some who are less good. But if you are doing well and you want to make sure you do everything that you can to keep your driving privileges, Just make sure you're as good as you can be about taking your meds and talk to your doctor if you need to about ways of making it easier to remember all your doses. There are various tricks and strategies. And if it's hard for you to remember multiple doses a day, ask your doctor if you can be on once a day medication. I do once a day medication for a lot of my patients to make it as easy as possible for them to take all their doses so that it can don't forget their doses and they have their medication on board, and that's going to reduce the chance of them having another seizure. Um, if you do have a seizure, make sure you ask your loved ones, your friends, or whoever has seen them, ask them what happened. What do I do? What happens to me during a seizure? What is it like? You need to know, do you blank out? Were you unresponsive for a period of time? Or did you appear completely with it and alert the entire time? Because that's a key factor in determining whether it's safe for you to get behind the wheel. Obviously, please be honest with your doctor and others. Please do not risk disaster. That's part of the reason I told you that admittedly very terrible story that I told you before, is because I just want everybody to realize that sometimes there are terrible consequences of these things. We not only, obviously, we don't want you risking yourself, but we certainly don't want you risking other people on the road. We don't, you'll if you do that because you were irresponsible and drove when you knew you shouldn't be driving, you'll just never forgive yourself for that. And I don't want anyone to ever be in that position. Um, One of the things that I tell my patients often in terms of organizing their lives, when you have epilepsy, it's a thing you have to think about. Even there are people, lots of people with epilepsy who do well for a really long time. Then they have one seizure, and then they go back to doing well for a really long time. So if I told you, if God, sent you a message from heaven and told you your epilepsy is going to do very well, you're only going to have one seizure in the next 8 years, you'd say, well, that's great. My life is going to be like almost normal. That's not bad. I'm doing pretty well. And your life would be just about normal, except for the fact that when you have that one seizure, you're not going to be able to drive for a whole bunch of months. So I always tell people with epilepsy, if when you're doing well, you need to make a contingency plan for how are you gonna run your life if a seizure does happen? How am I gonna get to work? How am I gonna do my shopping? How am I gonna socialize? How am I gonna do my other duties? Think of that stuff in advance if you can, so that you have a contingency plan, because then if you do have the one seizure, and God, I know that it sucks. And all of us who take care of patients with epilepsy, we know it sucks. You have that seizure, and I was doing so well, and now I can't drive for 6 months. We know how much it stinks. But it stinks less if you have a plan and you at least know what you're going to be doing for the next 6 months. And you and your doctor can work on improving things, changing, maximizing your medications to make sure that, that 6 months is all it is, and then you can get back to driving again. Another thing I tell patients is consider where you live. I know not everybody's a city mouse. Some people are, some folks are country mice, and that's totally cool, obviously. Different strokes for different folks. And there are many great things about, rural and suburban lifestyles, but you do have to recognize when you have epilepsy that if you live, in the suburbs, in many suburbs, and if you live out in rural area, then your ability to do things without a car is going to be very limited, right? If you have epilepsy, it's worth thinking about whether to live in a place that has public transportation. It's worth thinking about whether to live somewhere where there's stuff to walk to so that you're not, marooned in your house if nobody can drive you. It's worth living someplace maybe where you have the support of family and friends so that you have other people who can get you around in case you do have that seizure and you can't drive for 6 months. In rural living, it's very, very difficult because, obviously you can have the support of family and friends. Walkability and public transportation generally don't exist in rural locations. If you're a suburban kind of person, there are a lot of suburbs that have downtown areas where you can walk to things and where there may be, buses and trains available. And, it may sometimes be worth thinking about whether that's a good way to organize your life so that you are not so curtailed in your activities if you do have a seizure. Finally, it's worth saying something about self-driving cars. People with epilepsy sometimes are very excited about the prospect of self-driving cars. A lot of people are, and boy, I don't blame you. In the long term, when self-driving cars really work well, I think they might completely transform what we do for epilepsy care because obviously so much of quality of life in epilepsy in the United States is dependent on driving. But in the short term, I think their impact is much less clear. I think once self-driving cars get on the road, I mean, I will states will they still require that you have a valid driver's license in order to operate a self-driving car? I think they may well do that. Might they say that you have to be a legal operator or a functional operator? Um, I don't know. It's not like we don't these laws don't exist yet, but I have a hunch that states might do that. And if they do that, it may be the case that, the risk of you operating that car is low, but legally you may still not allowed to do it. So I think in the long term, many years from now, self-driving cars may actually be a huge boon to people with epilepsy. But for the short term, I don't know that anything is going to happen for a while. I think it will take a while for self-driving cars to be around before we can look into issues of, people with epilepsy using them. So I'm going to circle back to that case that I started with. I say case answers question mark because I'm going to give you my answers, but these are all tricky, murky issues. And so other doctors might give you different answers. So that was a patient, as I told you, who had psychological seizures, but she hadn't had an epileptic seizure for 3 years. If she came to see me, I would tell her that she is okay to drive. And I would say that regardless of what state she lives in, because she hasn't had an epileptic seizure for 3 years, and that's a good long time. I allow patients with psychological seizures to drive. I already explained my rationale for that, but not everyone agrees with me. Remember, she wanted to get pregnant too. So if she wanted to come off meds completely, said I want to see if I can go without medications because I think that would be the safest and healthiest thing. Okay, I would say that's fine with me, but you got to hang up the car keys for 3 months. That's the rule in my practice. Again, different doctors have different rules, but that's what I do. If she wanted to switch medications, if she said, all right, I'll stay on medication, but let's switch to a different one that is safe in pregnancy, I would not restrict her driving that in that circumstance. I do allow people to continue driving if they switch from one medication to another, because I don't have any good data that they're really going to put themselves or other people at a significant extra risk by switching medications. So in summary, just to sum up everything we've talked about, state laws around driving vary a lot, but locally, you have to be seizure-free for 6 months in Pennsylvania and New Jersey, or 3 months in Delaware. Pennsylvania, as we went over, has specific exceptions to allow for driving if you've had a seizure. All three of the local states have mandatory seizure reporting laws. The physicians, nurse practitioners, physician assistants have to report these seizures to the state. A witness history of what goes on during your seizure may be crucial in determining if you can safely drive or not, depending on what you do. There are a lot of driving issues that are not covered by law. Those issues are complex and physicians' views on them can vary. And finally, if you have seizures and you want to drive, consider your life situation and how you might accomplish things in your life if you do have a seizure, if you have seizures infrequently enough that you can still drive sometimes. Think about how to organize your life so that you don't get put in a bind in case you do have a seizure. And that was all I had today. And I thank you for your attention. And we have, I guess, 5 or so minutes for some questions.
All right. Thank you, Dr. Mintzer. That was so educational for us. Okay, so let's go to the chat. We have one question that says, how can you prove your aura?
Oh, how can you prove your aura? Oh, okay.
Mm-hmm.
Well, the way you would the way you would prove your aura is again, if you had a witness and you actually just told them, "Oh, you know what? I'm feeling my aura right now. I have that funny feeling in my stomach. This is what happens before my seizure. Right now, I feel like I'm completely alert. I can talk to you. Am I acting funny? Am I okay?" If you interact with someone for a while and you interact with someone for several minutes, you've then proven that you're capable of interacting and you're capable of navigating your environment basically. If you let's say you did that and after 5 minutes then you went into your seizure, well, you actually just you showed someone that you were having your seizure. You knew that it was happening, but you were completely awake and completely aware for several minutes. So that would be the proof actually that you that you were aware during it and that it was long enough.
Okay. Okay. Another question says, what medications are recommended, if any, for psychogenic seizures?
So psychogenic, this is that I'm glad somebody asked that. It's very important. Psychogenic seizures do not respond to medications. And it's very important to recognize that they are very different from epileptic seizures in that regard. The only treatment available for psychogenic seizures is psychological counseling. You must talk to a psychologist to determine sort of for most people, you have to talk to a psychologist about what is at the root cause of the psychological issues coming out this way. And that's the only way you can get them to not come out that way. For other people, when you can't get to that root cause, there's a different kind of therapy called cognitive behavioral therapy, where basically the psychologist can help train your brain to react in a different way to the psychological trauma so that it doesn't come out in a seizure. But medications will not treat those. And it's important to recognize that they won't be treated with medications because you have to do different things for them.
Okay, thank you. I don't know if you can answer this question, but someone asked when you can't drive, so essentially when you've reported it to the state, what happens to their actual physical license? Is it taken away?
Okay, so generally what will happen is it is reported to the state will send you a form that says you need to get this form filled out by your doctor. And if you don't get the form filled out by your doctor, then they'll just suspend your license. But then if you send the form in, the physician will fill out the form, and then the state will suspend your license. So what will happen is your license will go down in the database as suspended. I heard recently of some cases where some people actually had to mail their license back. Often they don't do that. They'll often just put your license down as suspended. That's just as bad or good, depending on how you want to put it. Because if you get caught driving with a suspended license, like if you drive and you get pulled over and the cop finds that your license is suspended, you are in a world of hurt. They will punish you, unfortunately, for that very, very severely. So please do not try to drive on a suspended license. I've actually had patients do that and get themselves in a whole mess of trouble. I mean, they actually they face jail time, but even if you don't actually get put in jail, there's huge fines, and it's really bad news. So you often they will just put your license down as suspended. If they don't take it away physically, that makes it easier for when they reinstate your license, then they don't have to send you a new card. You can actually just start driving on it again. And if
Okay.
they do take it away, in a few cases I've heard you can actually get a state ID that functions as an ID for you to get into things, et cetera, just doesn't allow you to drive.
Okay. And just to continue on that note, um, I don't know if you would have the answer to this question either. But how long before your license is that you don't have your license where you would have to redo a driving test?
Oh, that's a good question. I do not know the answer to that question though. That's gonna vary by state. I don't know if a license is inactive. I would bet that would be a bunch of years, but the truth is I don't know the answer to that question. Oh, that's
Okay.
Maria asking the question. Hi, Maria. How are you? Good to talk.
Okay. Can the stress seizures present or turn into grand mal seizures?
Can stress seizures turn into grand mal seizures? No.
Hmm.
Stress seizures do grand mal, what we call grand mal seizures are epileptic seizures. Some people can have stress seizures that will involve a lot of convulsive movement of the body, but they're not actual grand mal seizures. So that's good news because they're not harmful to you in the same way, and they're not harmful to your brain in the same way. They may look a little like grand mal seizures, but a seizure specialist can certainly tell the difference between them. And it's extremely important to distinguish between stress seizures and actual grand mal seizures because, as we already talked about before, stress seizures do not respond to medications. Grand mal seizures will require medications, and stress seizures do not respond to medication. So it's very, very important to make the distinction between them.
Okay. Our next question is if seizure pattern changed to only in the morning and diagnosed with drug resistant seizures, can the person drive?
That's a good question. So as I mentioned during the talk, there are some people who have certain kinds of epilepsy where they only have a seizure within the first hour of waking up in the morning. And that's the only time they ever have a seizure. If you had seizures like that, even if they were drug resistant, you in the state of Pennsylvania for sure you could be allowed to drive. It would be dependent on that's literally the only time you ever have a seizure. Um, for a lot of people with drug-resistant seizures, maybe I have most of my seizures within an hour of waking up in the morning, or I have 90% of them that way, but I've still had a couple where it was later in the day. If that's the case, then unfortunately it's not safe for you to drive. But if that's absolutely 100% of your seizures occur within an hour of waking up in the morning, then yes, you would, I think, be allowed to drive even if the seizures were resistant to medications.
Okay. All right. So we do have a lot of other questions.
I'm going to go for another couple minutes and then we'll take a break. Up to you.
Yeah. Let me see. So okay, this one says, as a teen, my last seizure was at the end of January 2024, and a second medication has been added to my regimen. I'm hoping this will be the answer. What proof is needed for the DMV to allow me to get my learner's permit?
So far, you have to ask the state specifically about learner's permits, but so far as I'm aware, I believe the only proof that's necessary is that for your doctor to say that you have not had a seizure for 6 months. I believe if you've not had a seizure for 6 months, you should be allowed to get your permit, I believe, by state law, unless they have more strict laws for the permit than for general driving. But I'm not, so I have to, I'm not 100% sure about this, but I don't believe that they do in Pennsylvania. So I believe at the end of July or the beginning of August, I believe you could go to the DMV and say, as long as your doctor fills out a form to say you haven't had a seizure in 6 months, then I believe the state would allow you to get a learner's permit at that time.
Okay, I'm going to have one last question here. And it says, is the proof of diagnosing the psychogenic seizures a negative EEG?
So we demonstrate psychogenic seizures in two ways. Number one is that you have an EEG during the seizure and we don't see anything. And number two, we also look at the pattern of body movement during the seizure. There are patterns of body movement that are characteristic and tell us that the seizure is epileptic. And there are other patterns of body movement that tell us that the seizure is a stress seizure. I can't get into the details of what all those things are because it's too complicated, but that it's the video appearance of the seizure often is a very important way that we diagnose stress seizures. It's that and the negative EEG both influence how we make that diagnosis.
Okay. Thank you so much, Dr. Mintzer, for everything that you shared with us this
My
evening.
pleasure. I hope this was helpful to people.
It definitely was, I'm sure. Okay, we're going to take our break. What time is it? We will return at 10 after 7. Have a good night, Dr. Mintzer. Okay, welcome back, everyone. I hope you had a good break. Now, it is my pleasure to introduce to you Dr. John Khoury. Dr. Khoury is currently serving as President of Abington Neurological Associates and is the Associate Director of the Abington Hospital Sleep Disorder Center at Abington. He also serves as the Principal Investigator for clinical trials in sleep and other neurological disorders. Welcome, Dr. John Khoury. I'm going to stop share so that you can have the screen.
Thank you very much, Janet. You guys can hear me okay? Just want to do a mic check quick before we start.
Yep, you sound good. Great.
Awesome. Thank you. And I will share my screen here. Share. Share entire screen. And way. All right. Is the screen viewable now for everyone? You can see the talk?
Yes. Yep, looks good.
Awesome. Well, thank you guys very much. I really appreciate the invitation today. It is always nice to talk about sleep and epilepsy together. And I am very excited to talk to you guys about this. I want to thank IFIPA for inviting me today. It's really nice to talk about these things. I'd like to just kind of give you a little bit of an overview of the slides and how we'll go through this. First, we'll talk about normal sleep so we can understand normal sleep and have a basic understanding of why we sleep. And I think we always ask why we do that. We'll talk about sleep-related epilepsy, of course. We'll talk about sleep issues that are unique to patients who are living with epilepsy. We'll talk about common sleep issues and their treatments. And then I will give you my tips on how to get a good night's sleep, keeping in mind that everyone is going to give you tips that are a little different. So just to go way back into 3rd century BC, Aristotle actually was one of the first people, actually the first documented recording of somebody who discussed a link between sleep and epilepsy. His book, Et Somno et Vigilia, translates to On Sleep and Sleeplessness. And then Galen in the 2nd century AD warned epilepsy patients about sleeplessness. He actually would say that a lack of sleep would cause an imbalance in the body, and this might trigger a seizure. So there was some understanding of this over 1,000 years ago. In 1881, Gower did actual research and found that 21% of patients with epilepsy seized solely during sleep. And then in 1947, Gibbs found that sleep activated spikes and sharp waves on EEG, and we refer to this as interictal discharges. So if you've heard that term before, you see it on an EEG report. We're referring to the term spikes and sharp waves. And what that means is somebody who has spikes or sharp waves, that's a tendency to have a seizure. That might be an area of the brain that has cortical irritability or an area that might be where your seizures are coming from. And that's why we do EEGs. So the most common sleep disorder, the most common problem that we have, the reason that we are so tired during the day, I want everyone to kind of think about this, but what might the most common sleep disorder be today? The most common sleep disorder that we have is that we don't get enough sleep. We simply do not get enough sleep. Back before the light bulb, patients got more sleep and everyone got more sleep. And as we became a more modern society, lights came on, we had brighter lights. And if you live in a city, there are lights on essentially 24 hours a day. And so there is a tendency to stay up. Lights keep us awake. And the more light we have, the more reasons we have to stay awake. And now we have TVs in the room. So not just do we get lights, we get light that interacts with us and actually releases dopamine when we watch or when we are on our phones and we're clicking the like button. We're increasing dopamine response to the brain, and we are promoting wakefulness at the detriment of our sleep. So the longer society goes on, I think we maybe get less and less sleep as we get more and more electronics in our lives. This is why sleep doctors always will tell patients, Try to avoid things like the cell phone in bed, and we'll get to parts of that talk a little bit later on. So the most common sleep disorder is something that you today can fix. Try to get more sleep and make sure that you schedule enough time to go to sleep and stay asleep. And if you have epilepsy, this becomes so much more important because the lack of sleep can trigger a seizure. And given the room and people who are watching, I'm sure many of you may have triggered a seizure because you accidentally stayed up late at night, or you got very busy with work and you couldn't get enough hours of sleep in, and that may trigger a seizure. And so we always tell our patients to get enough sleep and make sure that they dedicate enough time to getting sleep. So how much sleep are we supposed to get? These are recommendations from the National Sleep Foundation. If you look at the bottom half of the deck here, kind of age 14 and up, I think, which would be more relevant to most of the audience here. Recommended hours is here in the left-hand column. And if you ever get asked the question, how many hours am I supposed to sleep? Don't worry, there's a nice chart for you. Of course, we all have this idea of 8, and in the 7 to 9 range for most adults is pretty good. However, what can be appropriate for some patients is as low as 6, and for some patients as much as 10 or even 11 in the young adult range, and that is considered normal when you look at these age ranges here. So we have on the young adults here, young adults may need as little as 6, or as many as 10 to 11. Older adults may need up to 10 or up to 9 hours of sleep, depending on their age. And so every person is different. This is related to genetics, medications, and your overall health. So there's not just one thing here, and this will change over the course of your lifetime. You may be someone who only needs 6 or 7 hours in your younger years and then needs more like 8 or 9 in your older years, or vice versa. So you can go from one end of the spectrum to the other as we get older. So you just need to understand that sleep is variable from person to person. And on my far right column, it is what we have is not recommended. And for patients with epilepsy, the most important thing to be aware of is the low end, because low end is really what may trigger you to have a seizure. But let's say you're someone who always needs 9 hours of sleep. That is just the amount of time that your body requires. You getting 7 hours of sleep for a few weeks is actually sleep depriving you. And that might potentially lead to a seizure for you if you are someone who really biologically needs 9 hours of sleep. So keep in mind, you want to make sure you get the sleep that you need, and you will do that by setting a wake-up time. You start by setting a wake-up time when you decide how much you are planning to sleep or need to sleep, because most people will go to work, start their job, have to deal with kids, so they have a wake-up time that's set. Calculate backwards to figure out what time your bedtime should be so that you can get to bed and get to sleep at a regular time and get the sleep that you need, waking up hopefully feeling refreshed. I would like to talk a little bit about the circadian rhythm. Although we all know about and hear about our circadian rhythm, this actually won a Nobel Prize a few years ago. It was discovered that every cell in your body has a clock gene. There are genes in every single cell, your heart, your lungs, your muscle cells, and of course your brain, that have genes that are related to the time of day. Your brain sends a signal to the rest of the body as to what time it is. And this is how our body knows how to act when we are asleep and when we are awake. So if you look at this 24-hour clock, you can see that we get increases in blood pressure in the early morning. We get high levels of alertness, usually right after we wake up, within that first few hours. Sometimes a little bit of caffeine certainly helps. We get that midday time here around noon. Coordination time and fast reaction times tend to happen in the earlier afternoon. Our highest body temperature is around 6 p.m. Our highest blood pressure will be a little bit later on. Melatonin gets released in the brain, and then we will start to go to sleep and start to fall asleep. And then our lowest body temperature is in the early morning. It tends to be around 5, 6 o'clock in the morning when we have our lowest body temperature. The secretion of melatonin is incredibly important because That's what cues our body to help fall asleep and to help our body know that it is time to go to sleep. And many patients will take melatonin as an over-the-counter medication to help with sleep and sleeplessness. So why sleep is important? As I already mentioned to you, every organ behaves differently during sleep. We have clock genes in our brain that signal the rest of our body what to do. Our body and our brain consolidate energy. Energy is spent towards cellular repair and growth. And our body will work on growth hormone and release growth hormone when we're young. Sleep actually enhances mood. When we get normal night's sleep, we'll have better moods in the morning. And one thing that is new, and for those who are scientific in the room, again, something discovered, has not won a Nobel Prize yet, but certainly may, something called the glymphatic system. This is how our brain removes waste products removes waste products from the brain while we sleep. This new glymphatic system that was discovered within the last 5 years or so, maybe 10, basically shows that our brain creates waste products during the day. As we are awake and expending energy, our brain creates waste. It is spending energy, and we have to get rid of that energy and that waste product somehow, these byproducts, and this is removed through the glymphatic system. And of course, we know that sleep consolidates memory. This is why we tell all our children to get good night's sleep so they can do well in school. We make sure our kids get a lot of sleep before they take their SATs. And because we know sleep consolidates memory and helps improve performance. So this is why we work on getting good sleep and making sure that we try to get good sleep for ourselves. I think for most of us, we're more likely to tell others to get good sleep, and we sometimes don't look inwardly to say, am I getting enough sleep for what I need? So I'd like to talk about the stages of sleep and some common misconceptions about sleep. There are 4 stages of sleep. There actually used to be 5, much around the time when Pluto was no longer a planet. They removed what was referred to as stage 4 sleep. So stage 4 sleep and stage 3 sleep are now the same. So that is all considered stage N3 sleep. So we have these 3 states of being. We are either awake, we are either in non-REM sleep, or we are in REM sleep. So we are in one of these 3 states at all time, and we're very rarely in transitions. Transition is a period of brain instability as our brain waves are changing from one sleep state to the next, and these transitions can actually trigger sleep stages. Can actually trigger seizures, sorry. So stage N1 sleep is right here. You can take a look here, and we see this kind of irregular low amplitude activity. When you look at this area above, this is relaxed wakefulness. If I'm just sitting with my eyes closed, this is what a single EEG line may look like in the back of the head. We call this our alpha rhythm. We then go on from stage 1, which is light drowsiness sleep and light sleep in the beginning of the night, on to stage 2 sleep. Stage 2 sleep will comprise most of our night of sleep, and is actually one of the stages where we're most likely to have a seizure. Stage 3 sleep is N3 sleep, referred to as slow wave or delta wave sleep, and you can see these very large amplitude brain waves here. And then finally, we have REM sleep, which is called rapid eye movement sleep. And if you look at rapid eye movement sleep, the speed of the brain waves much more resembles maybe a combination of stage 1, stage 2, maybe a little bit of this relaxed wakefulness. The speed of the brain is nothing like stage 3 sleep. So a lot of times a misnomer of stage REM sleep is deep sleep. Neurologists, sleep specialists refer to deep sleep as slow wave sleep and stage 3 sleep. And we refer to REM sleep as its own entity, stage REM sleep. And this is what REM looks like on one line on an EEG here. So these are the stages of sleep, and we transition between these stages throughout the evening. In the beginning of the night, we are more likely to have stage 3 sleep and low slow wave sleep. And we'll then go through REM sleep, and we will cycle through that REM sleep every 90 minutes or so. What if you look here at this, what we call a hypnogram, you'll see that we get most of our REM sleep towards the end of the night. Towards the end of the night is when we get most of the REM sleep, and that is a very, very refreshing sleep and a very restorative sleep. It is the type of sleep that you will feel when you are dreaming. That's usually when you have the most vivid dreams and most active dreams. And if you're a patient with epilepsy, REM sleep is actually most protective against seizures. It's very rare to catch seizures in REM sleep, and it's also very rare to catch spikes and sharp waves in REM sleep, if at all. So we go through these cycling every 90 minutes or so. There's a little bit of exaggeration on this curve here, but this is normal sleep cycling here. And you can see when we would have dreaming during our REM sleep, stage 1, stage 2, and stage 3 sleep. It is important to know that our sleep worsens as we get older. As anyone knows, we don't sleep the same way we did when we were teenagers. Teenagers get lots of stage 3 sleep, and young adults get lots of stage 3 sleep. But as we get older, our stage 3 sleep starts to dwindle. Our REM sleep starts to dwindle. We get a lot more awakenings in the middle of the night as well. And so, unfortunately, that's just a part of normal waking and normal aging. So there are epilepsy syndromes that are directly related to sleep. In fact, the very first epilepsy syndrome, autosomal dominant nocturnal frontal lobe epilepsy, was the first epilepsy they actually discovered a gene for. So if you have nocturnal frontal lobe epilepsy, more than likely it is gene related, and is the very first epilepsy where a gene was discovered. It has a very unique type of seizure. These seizures may be much briefer than other seizures. There can be partial awareness or loss of awareness during these seizures, and they are very, very unique from that regards. There is benign childhood epilepsy with central temporal spikes, often called Rolandic epilepsy. There's a form of epilepsy called generalized tonic-clonic seizures upon awakening, where patients have a seizure immediately upon awakening or within about an hour after awakening. And Dr. Mintzer had mentioned earlier in his earlier talk that sometimes in some states, patients who have seizures only upon awakening are able to drive. You have continuous spike wave discharge of slow wave sleep. When you saw earlier, I showed you those nice slow waves. We can sometimes see spike and waves, which are epileptiform activity, buried in these slow wave sleep. I've actually personally only seen 2 cases of this. Usually this is diagnosed when somebody is young, but I caught a woman in her late 20s, early 30s, who had never been diagnosed with this. And when she told me her story, that she would go through these staring spells and they would happen at all hours of the day and even in the middle of the night, I said, if this isn't spike wave, slow wave sleep, or spike wave stupor, then nothing is. And sure enough, we were able to capture these events and diagnose her with spike wave discharge of slow wave sleep. And then there's juvenile myoclonic epilepsy, where patients have myoclonic jerks upon awakening. And they then tend to dwindle off throughout the rest of the day. And this is actually very indicative when we hear an epilepsy patient tell us, I wake up in the morning and I get these muscle jerks or little quick jerks in the morning that last maybe a few minutes or a few seconds, and then they seem to go away throughout the day. That's often going to be juvenile myoclonic epilepsy. So there are epilepsy syndromes that are directly related to sleep and that are directly linked to sleep. But transitions in sleep, as I mentioned earlier, may increase seizure frequency. There is an instability that happens when we are going from awakefulness to sleep, from stage 1 to stage 2, stage 2 to stage 3. We get a lot of EEG changes. And when the EEG is changing, when our brainwave is changing, we are at risk to have a seizure. And that's why stage 2 sleep is one of the greatest risks of having seizures. And as I mentioned earlier, REM sleep is protective against epileptic activity. And that might be because the EEG in REM sleep is a little bit more disorganized and less synchronous than other stages of sleep that tend to be much more rhythmic in patterns. So your doctor will ask you if you have epilepsy or if they are being worked up for epilepsy. Your doctor will ask you for an EEG. Sometimes they'll just do an EEG right on the spot in the office, or sometimes they will ask you to do an EEG with sleep deprivation. You may have had a normal EEG, and the physician thinks, I really think this patient has epilepsy, I'm trying to prove it or catch some sort of evidence. And so we'll ask patients to come in and we'll ask them to sleep deprive themselves or ask them to stay up very late and wake up very early in the morning so we can induce some non-REM sleep and we can get some state changes, some changes from wake to sleep while you're on an EEG. So we can capture epileptiform activity, find a spike or a sharp wave, and that will help us prove, yes, this person has epilepsy or this person has a seizure or has had a seizure, and this will help us make that diagnosis. Keep in mind, normal EEG is common for patients with epilepsy. So just because you've had a normal EEG, that doesn't rule out epilepsy. And sometimes we can even see spikes or sharp waves on people who don't have seizures or have never had a seizure. Maybe they were ordered an EEG for the wrong reason. And we find evidence that there might be some areas that could potentially seize, but they've never had a seizure before. So it is very important to talk about the testing. And personally speaking, I would say I would never get an EEG unless ordered by a neurologist and maybe a pediatrician. Pediatric general doctors tend to have a lot of seizure experience, but you do want to make sure you're getting the EEG for the right reason. And so a neurologist is really the best person to order the EEG, and an epileptologist would, of course, be the best person to help interpret that EEG, or a neurophysiologist. Patients with epilepsy are at an increased risk of pretty much every main sleep disorder, but they have higher risk of insomnia, higher risk of hypersomnia, which is the medical word for sleepiness. They're at higher risk for obstructive sleep apnea syndrome, restless leg symptoms, which are creepy crawly sensations and tingling sensations on your legs at night when you try to sleep. And then another disorder called periodic limb movements of sleep, which can actually only be diagnosed with an in-laboratory sleep study. Your legs are literally twitching at night, and that can cause arousals in the middle of the night, which can keep you awake or maybe wake you up, and you're not even aware of that. And that's what a sleep study can help us determine. For patients with insomnia, one of the best things that they can do is work on things like relaxation and take a look at their medications. Some medications can cause insomnia. Similarly, patients with epilepsy are at higher risk for hypersomnia or sleepiness because a lot of the meds that we prescribe for epilepsy cause sleepiness and cause fatigue. And what can be sometimes really hard to tease out when we start a medication like Keppra, which is called levetiracetam, is the medication causing you to be sleepy? Is the medication causing you to be fatigued, which is not quite sleep, just this kind of general feeling of unwellness or tiredness. But if you tried to lay down and sleep, you wouldn't nap. That's how fatigue is different than sleep. Or is the medication showing us a symptom of another sleep disorder you already have, but maybe were never diagnosed because you never saw a sleep doctor before or never had a sleep study. Because the prevalence of sleep disorders is so much higher in people with epilepsy, I usually recommend if there's any sort of sleep symptom or sleep disorder, make sure to talk to your epileptologist about it, your neurologist. And if you're in an area where you can see a sleep specialist, it's worth it to get a consult just to ask, what might you be at risk for? And again, as Dr. Mintzer mentioned earlier in his talk, if you have a partner or someone who can tell your doctor about your sleep, that way we can also interview somebody and get more information, because you're asleep. What would you know is happening while you're asleep? There may be weird things that are occurring to you and you just don't know it. I would like to take 30 seconds on this because this test is so important when it comes to sleep and sleepiness. If anyone here has a pen and paper and pencil, or just wants to run these numbers in your head, this is called the Epworth Sleepiness Score. This is your chance of dozing off, not necessarily going out to sleep and getting knocked out or fully napping, but what are the chances of dozing off in these situations? So you have no chance of dozing off, a slight chance of dozing off, a moderate, or a high chance of dozing off? So let's say you're sitting and reading a book. If you're doing that all day long or frequently and you never doze off, that's great, that's a 0. But if you find yourself frequently picking up and saying, oh my gosh, where did I lose myself? Where did I get left off? You've got a high chance of dozing off. Similarly, watching TV. Are you able to sit through a movie? If you can't sit through a movie, you have a very high chance of dozing off. You should be able to watch movies without an issue. That's about 2 hours in a dark room without falling asleep or dozing off. And maybe the movie will make a difference if it's the Marvel movie or if it's some sort of indie flick. But I mean, you should be able to stay awake through movies. If you're sitting inactive in a public place, a theater, or a meeting, dinner event, or at work, obviously that is a problem. If you're a passenger in a car for an hour without a break and you are dozing off, again, that's abnormal. Lying down to rest in the afternoon when circumstances permit. Now, napping is certainly reasonable, and if that's the only thing here that you're positive for, that's not an abnormality. If you doze off sitting and talking to someone, of course, that should not happen. Even the slight chance of that happening may be unusual. Sitting quietly after a meal without alcohol, again, if that causes dozing off for you, that would be an issue. And if you're driving in a car while stopped in traffic, even a slight chance of nodding off or dozing off should be looked at, especially if that driving is not for a long period of time. So if you've looked through these tests and you've done this score and you find that your score is 10 or higher, there's a very, very high chance you have a sleep disorder and you should be looked at. Similar, if your score is in the 8-9 range, there might be a sleep disorder. Maybe you're not getting enough sleep, and you could work on that. And the lower the number is, the less likely you are to have the sleep disorder. But I have seen patients with zeros on this and have problems with their sleep. And again, if that is the case, please talk to first your neurologist and then maybe a sleep doctor if you have access to one. It is not a talk on sleep and epilepsy if you are not talking about the medications. There was a very, very nice review article published about 2 years ago, just after the pandemic, that looked at medications known to cause sleepiness. And this article actually was able to pull up what the FDA found, the warnings you get when you get a medication. And they were also able to find smaller studies and publish those in this review article. This is a great article. We could talk about this article probably for 10 hours because they go through every single medication. But if you take a look here and look to see where your medication might be, we can see that this medication where I'm looking at, this medication list, this is what the FDA believes causes sleepiness and tiredness and fatigue. And you see there is a lot of them on here. Topamax, Depakote are very common ones. Oxcarbazepine, Keppra or levetiracetam, probably now the most common one out there. Lamotrigine or Lamictal is on here, and I'm going to show you that there is some non-congruent data here. And there is some things that are on both the sleepiness list from the FDA and the insomnia list from the FDA. So we can see that there are some medications that are actually seen on both. Most epileptologists and neurologists will tell you that Lamictal, of everything that I've listed here, probably has one of the higher incidence on a real-world basis of causing insomnia and causing sleeplessness. So if that is the case for you, talk to your doctor to see if you could potentially take your second dose of Lamictal or Lamotrigine a little bit earlier. Perhaps the longer acting version of Lamictal or Lamotrigine might be better for you. But Lamictal does help with mood. And of course, we know helping with mood helps with sleepiness. Every patient is different. So it is really important to try to take some stock of what your sleepiness is and fatigue levels are before you're switching medications or maybe before you start a new medicine. Just take a look and write down what your sleep times are, how you feel in the morning, maybe take an Epworth to help understand what level of sleepiness or insomnia you have. And that way, if you do start a medication and 3 or 4 months later down the road, you can say, I feel more tired than normal. Am I sleeping more? Am I sleeping less? You can go back and see, what was I sleeping like before I started Lamictal or Trileptal or gabapentin? And many drugs we even use sometimes for sleep. So gabapentin is listed here as possibly causing insomnia, but many sleep doctors and many epileptologists will use gabapentin to help with sleep. So there's a lot of information when it comes here to the insomnia and hypersomnia causes of medications that may not match up and might might contradict each other. And that's why it's important to talk to your doctor to get real world experience as opposed to what is just listed on the FDA in clinical trial and clinical trial settings. The effects of epilepsy surgery and sleep. Perhaps there are some patients in the audience who have already had epilepsy surgery or who are contemplating epilepsy surgery. We know that better sleep measurements correlate with better seizure control. So we know epilepsy surgery causes or helps improve seizure control. And we know that because of that they get better sleep. We know that epilepsy surgery increases REM sleep duration, which is that good type of sleep I talked about earlier. We know that REM sleep decreases daytime sleepiness. It improves the Epworth Sleepiness Score, which we did earlier. And epilepsy surgery also improves the Pittsburgh Sleep Quality Index, which is, again, I didn't go through that here, but it's another sleep tool that is often used in offices. When preparing for this talk, I looked to see what about the time of sleep. There are some conflicting data. Some epilepsy surgery, some studies show that epilepsy surgery may increase your total sleep time, and some say they decrease your total sleep time. So it's really kind of too close to call right now. But we do know that we see better sleep outcome measures after epilepsy surgery, especially in patients who have better seizure control, which makes sense because epilepsy messes up your sleep, even if you're not seizing in the evening or just before bedtime. Vagus nerve stimulator and sleep. We know that the vagus nerve stimulator reduces seizure frequency. It is great at reducing seizure frequency, but actually it may increase obstructive sleep apnea events. And we will talk about what obstructive sleep apnea is a little bit later on. But it may increase these obstructive events. And again, that's treatable. We have treatments for obstructive sleep apnea. So this doesn't increase it enough that I would say, oh, don't get a vagus nerve stimulator. But if you are someone who's at risk for sleep apnea, you may want to consider treating your sleep apnea first before getting a vagus nerve stimulator. There are some patients who do shift work and who have epilepsy. Now, generally, if you were to come to my office and ask me, I have epilepsy, should I take a night shift job? I would say no. I would, and I think most of us would tell you no, because your night shift job is going to be so hard to maintain throughout the week. You're going to have some days, some nights, your shifts may change. But if this is absolutely unavoidable, if you have to be a person who works night and you're a person living with epilepsy, I would say keep the same shift if you can. And if you're not working, sleep on that same shift. So if you're working what's called the graveyard shift, 10 p.m. to 6 a.m., and then go to sleep at 8 a.m., go to bed at 8 a.m. all the time, and do not try to shuffle your circadian rhythm clock at a different hour when you're not working, because again, you will increase your risk of having a seizure because those changes of sleep, that change to your circadian rhythm is going to cause some instability and potentially cause or trigger a seizure. So ideally, you don't do any shift work, but if you do have to, try to keep the same shift. And I will tell patients with or without epilepsy, if you are going home after the night shift, put on dark sunglasses to prevent bright light from waking you on your way home so you can fall asleep better, hopefully in a dark room that you have created for yourself when you get there. So to talk about obstructive sleep apnea, it is probably the most common sleep disorder that presents to a sleep doctor. 30 to 40% of patients with epilepsy have obstructive sleep apnea syndrome, meaning they stop breathing in the middle of the night or their breathing is obstructed by their own airway. This is normal breathing here in green, you can see, where the airway is open and air flows freely into the lungs. And then we have an obstruction in the back of the throat. This can be weight. This is the weight of the back of the throat can cause collapse. And the heavier we are and the older we are, the more likely this is to occur. And there actually is some data that says treating obstructive sleep apnea will help reduce your seizure frequency. So if you are someone who is having problems with keeping your seizures under control and you're contemplating epilepsy surgery, if you are at risk for obstructive sleep apnea syndrome, please do a sleep study. Whether you do a home one or a lab one, you can talk about that with your sleep doctor. Generally, for patients with epilepsy, I would prefer an in-lab study, but if that's not doable or it's too hard for you to fall asleep in a lab, please do a home study at a minimum. Of course, we know about CPAP machines. CPAP machines are the gold standard for patients with epilepsy. There is an oral appliance available for patients with epilepsy as well. This is what this looks like. And what this device does is this pulls your low jaw. If you have obstructive sleep apnea and you don't want to use a CPAP machine, a patient may decide to use this to treat their obstructive sleep apnea by advancing the low jaw forward. And this is made by dentists. The biggest problem with the oral appliance, I would say, is poor insurance coverage. I think these would be used a lot more if they had better insurance coverage, but it is an alternative to CPAP for patients who have obstructive sleep apnea. And I would certainly encourage patients with epilepsy to consider it, especially if they do not want to use a CPAP machine. It is better than nothing for sure. You may have watched or heard a TV ad referring to Inspire for sleep apnea. And what the Inspire device is a lead that goes to the 12th cranial nerve, the nerve that stimulates the tongue, and it will stimulate our tongue and our airway to open up and actually move your tongue forward when you have an apneic event at night. So now we have a stimulator to keep the airway open. And again, if you're a patient with epilepsy and you can't use a CPAP machine, maybe you have a vagal nerve stimulator on one side, but you can actually still get this Inspire surgery to help reduce obstructive sleep apneic events. So in the last couple of minutes, I know I'm running short on time here, ways that you can improve your sleep. What I mentioned earlier is set a wake-up time. Do that first. Setting a wake-up time will help create and lock in your circadian rhythm. If you set a wake-up time, that will help hopefully make you sleepy at a specific time, the time that you should go to bed. If you are setting a wake-up time, let's say 7 in the morning, and you are still incredibly tired when you wake up in the morning, make sure you are adjusting your sleep time then. If you are sleeping and waking up, 7 or 8 hours, and you physically can't sleep anymore, your body just naturally wakes up, that's great. If you're feeling tired when you are still sleeping that amount of time, please talk to your neurologist about possibly your medications or a referral to a sleep specialist to see if you might have a sleep disorder. First thing to do when you wake up in the morning, expose yourself to bright light during the early waking hours. Again, this will help line up your circadian rhythm and your circadian clock. We don't want to do what this guy is doing here and give us bright light and dopamine in the middle of the night, because that will help keep us awake, which is not what we want to do. Avoiding caffeine after 1 to 2 p.m. We would like to keep caffeine out of the system. Many patients will say, oh, but doctor, I can drink caffeine at 6 or 7 o'clock at night and have no problems falling asleep. That may be true, but studies show even if you do fall asleep, your sleep is lighter if there is still caffeine in your system. So you may not be getting as good quality of sleep, and you just may not be aware of it. Of course, avoid alcohol. Alcohol should be avoided in the evenings for patients who are having problems with sleep. And probably for patients with epilepsy as well. The problem with alcohol is you will fall asleep because alcohol is a sedative. It's like a benzodiazepine, like a Valium or a Klonopin. As a sedative, it will then put you to sleep. But alcohol wears off and gets converted into a stimulant-like compound. And in the second half of the night, patients have very fragmented sleep. They might be awake, asleep, or have problems going back to sleep after the alcohol wears off. So avoiding alcohol in the evening or potentially altogether to help improve your sleep. Exercise daily. Morning exercise is great. Afternoon exercise is great. Evening exercise is great. There are studies that kind of look at what is the best time to exercise if you have sleep problems. No study has been consistent. So as a sleep doc, I will say any exercise is better than no exercise. I mean, I would probably avoid it an hour before bed, but after that, I think that would be enough time to try to go to sleep. Talk to your doctor if you're having any sleep issues, despite doing all the things you're, quote, supposed to be doing. In my last 30 seconds here, I want to show everyone this Michelangelo's Sistine Chapel. Whether you're religious or not, this is not really the point of this. Michelangelo drew this painting here with God giving, quote, life to Adam. But as a neurologist, I look at this a little bit differently. What I look here is I actually see a brain. I see that this picture here of God is actually coming to Adam in a brain, and he actually might be giving Adam knowledge. And why do I say this is because when we look at history and we look at people of the past, we sometimes discredit the knowledge that they had, but people have been thinking about the brain, people have been thinking about sleep and knowledge for hundreds and even thousands of years. They just don't understand it to the level that we do today. And thousands of years from now, they will understand the brain in a much different light than we are thinking about it today. So many of the information I give you may be completely wrong a few thousand years from now, but this is how we got to this. And that's what science is. It's constantly doing work, doing research, and getting to what hopefully will be one day the absolute truth. And that is everything for me. So I think I have a few minutes to take questions, I hope. And I'll open the floor up.
Yeah, thank you, Dr. Khoury. That was amazing. Okay, let's look at our questions. We have one that says, if I stay up late all night, or if I stay up late at night, but still get enough sleep till the next morning, so 8 hours, and may nap during the day, is that okay?
Yeah, so that's a circadian rhythm issue or question. And I think that is okay for most patients, especially if quality of life is good. I think, remember, quality of life matters when it comes to questions like this. So you might be someone who has a night owl, a delayed sleep phase. And believe it or not, as I talked about earlier, clock genes, there are genes that will keep us awake. And there are some people who are night owls, and there are some people who like to go to bed super early. So yes, that is technically, or it certainly can be okay. It just make sure it matters on quality of life. You're getting your 8 hours of sleep, and you feel good when you wake up during the day and are able to function and work and participate in life.
Right. All right. Thank you. Another question was, does the medication make you sleepy? But you answered that for us.
And they do. And that is definitely true. Medications do make us tired. Medications do make us sleepy. And the epilepsy itself also does that. So although, again, we talked a little bit about the meds and we have lists, but the seizures themselves also do that. But I also like to tell patients, don't blame everything on the seizures and don't blame everything on the medications. So that's why talk to your doctor, consider a sleep study if you're having symptoms of tiredness, fatigue, and that's something that can be evaluated, because it's always disheartening to know that somebody went 5 years without ever seeing a sleep doctor for issues that they had, and they may have had sleep apnea this whole time, and that could have helped their seizures, it could have helped their quality of life, and could have helped them feel better in the morning.
Okay, thank you. One other question says, is there a concerning amount of occurrences in an hour that are dangerous for those with seizures?
I'm not sure I fully understand that question. Oh, I think it might have been about apneas, maybe. I'm not sure if that was referring to apneas per hour. So we define sleep apnea as someone who has a pause in breathing between 5 and 15 events per hour. Then moderate sleep apnea is 15 to 30 events per hour, and more than 30 events per hour is considered severe. If you have severe sleep apnea, you must do something. You must use a CPAP machine. You must get surgery. You must do something. There's a very high risk of triggering seizures, bad quality of life, heart attack, stroke. I mean, the list goes on and on and on. So what could go wrong if you stop breathing at night, right? 5 is what we consider the lower limit. In that 5 to 10 range, it may not be that disruptive for some patients, but there are many patients who have very mild sleep apnea, and we say, well, let's treat you and let's see what symptoms get better. And this is basically the trial and error, or the art of medicine. So we don't know for sure what every patient is individualized. And so in severe patients, you absolutely must treat. And the milder cases, oftentimes this is a discussion with the patient and quality of life, and to see, does treating sleep apnea help or hurt your disease? And this is your own experiment, so to speak.
Okay, thank you. Another question says, is there a recommended time of day for napping? Is there a length of time that is too long for napping?
And I see here 2 questions on napping, and napping is always a great question. So I think appropriate naps are around the 30-minute mark, maybe 40 at the most. And the one person here said that their son was on a few seizure medications, and that could increase the need to nap. And you sometimes may actually need to sleep an hour or 2 per day. And the key point here that was listed in that one question was, they don't function well if they don't nap. And if that is the case because of the medications, the epilepsy, and the seizures, then that's just the way it has to be. I would say, though, consider if a sleep study has never been done on someone who is napping a long time, it really should be considered, even if you believe there is no sleep disorder. The mere fact of the matter that somebody is sleeping for a very long period of time, maybe sleeping 8 to 9 hours, and then maybe napping another hour or 2, you really want to make sure, hey, this is just because of my biology, my medications, and my disease, and not because I'm missing something. And so, yes, these things can be acceptable, but they should be worked up and they should be evaluated.
Okay, thank you.
Falling asleep and waking up are prime times for seizures. Yes, this is absolutely typical, because these are the state changes. Our brain is going from wakefulness to sleep and sleep to wakefulness, and our brain is transitioning. We often think that sleep is passive, or that we are just falling asleep and nothing is really happening. So much is happening. There is so much going on in the brain while we sleep. We just don't remember it happening. And that's part of why sleep was designed that way. Sleep was designed so that you don't remember all these things your body needs to do to function better. And so, yes, because of these state changes, there becomes more excitability and irritability in the brain. And that's why these can be prime times for seizures. And again, you may want to talk to your doctor to see if changing the timing of the medication can help reduce that. It certainly is not any guarantee that it will, but yes, that is certainly the case. Fly eagles fly. Yes, I agree with that for sure.
Okay, that is all the questions that we have. Thank you, Dr. Khoury, for having this great presentation on sleep and epilepsy. We know that is one of the biggest topics in the epilepsy community. So we thank you for your expertise.
Thank you for the invitation.
Right, you have a good night.
Thank you.
So thank you to both of our knowledgeable presenters this evening. We are so blessed to have them on with us today. Please take a minute to fill out our post survey that will be on the screen momentarily. Okay, so the screen, your survey should be on the screen. If you could just take a few minutes to do that.
Let's stop my share.
Thank you. Okay, and as you are doing that survey, we just thank you for joining us this evening. After you complete the survey, you can disconnect. We hope to see you at our upcoming events. Have a wonderful evening, and we will see you soon.